Hello everyone and welcome to the rounds for Telestroke demonstration. My name is Stephen Winters and I'll be taking you through a brief video showing you how to use the rounds platform to do a basic Telestroke consultation. First of all, this is a screen that will appear when you first load the platform. Simply log in with your username and password and this will then load the dashboard. The dashboard is a list of existing or pending consultations that have been performed on the platform, and as you can see they're nicely laid out by which hospital they were performed, what the patient's name was, when it was created, and the doctor that had performed the consultation, as well as the admission. Now to begin a new consultation, click Add Stay as I've just done there, put in the patient's MRN, add in the the first name and last name, patient's age, and the doctor that's completing the consultation. Click Create Stay. And as you can see here, the consultation that we've just added has now appeared at the top of the list. And by clicking Start, you can begin the Telestroke consultation. Now notice that the left side of the screen shows an existing list of consultations, and this is useful for someone who needs to browse quickly through some of the recent consultations that have been performed. But let's just focus on the middle part of the screen. Now because the Telestroke platform has been adapted from our main platform, this step allows the user to select the syndrome that applies to this consultation, but because this is Telestroke, the only option will be for stroke. So click Stroke there, and basically the layout is fairly intuitive. We're starting with the clinical history and we've got to basically work from top to bottom for each tab, okay? And if you are at the top of the page, you'll notice that you'll have a blue bar down here that says more content. That means that there is further parts of that page that need to be seen by scrolling down. So let's just quickly go through a mock consultation. So obviously this is asking for who's in attendance, and because it's under Tim Ang, we're going to start with Dr. Timothy Ang. The patient's obviously part of the consultation, and let's say that the wife and the daughter have also presented, and it's taking place at Port Macquarie Hospital. The next step is to select the nature of the timing of the stroke symptoms. So let's just say less than 24 hours, and because we know specifically when the symptoms started, so we're going to say today, and then the time. So at the moment it's 4:57, so we're going to say that they presented at about 3 p.m. in the afternoon. Okay, and presenting complaint, that's fairly straightforward. You've got some guides here that are used mainly for junior doctors for our main platform, but obviously important to note, patient was well earlier today, was having afternoon tea with wife, and wife noticed right facial droop and hand and arm weakness. Notice that those prompts are also on the right side of the screen. Wife called ambulance. Now unable to walk. Okay, and then we're going. The next obvious part of the consultation is background. So we're going to say that he's a smoker, he's hypertensive. He's got raised cholesterol, but no diabetes, no AF, no coronary artery disease, no previous stroke or TIA, and no chronic kidney disease. Now also note that you can add more information, which may be useful. So for smoking, 30-pack year history, and only recently commenced on medication last year. So we can close those, and those bits and pieces of information you can see show up here, and they will be added on to the final admission. Okay, so medications, not on an antiplatelet therapy, but he has been on a statin and an antihypertensive medication. You can add specifically what the name of those medicines are. So let's say atorvastatin, 40 milligrams, started by GP several years ago. That sort of detail is not necessary, but if you have that information, obviously it's useful to put that in. So perindopril, 5 milligrams. Close. Nil other medications. Known drug allergies. Social history, so obviously young guy, lives with spouse, or with family, no AIDS, no assistance, independent with ADLs, driving, employed, works as a plumber. Okay, so that's the basic part of the history performed, the examination. So we should have access to that information as the consultation takes place. So 130, so I'm just going to make up some numbers here. 6.7, obvious right facial droop, alert. And you can have the cardiovascular or other parts of the examination added there, but that's not necessary, totally necessary. Now for the neurological examination. So the National Institutes of Stroke scale has been deconstructed. All of the elements are present, but we've just rearranged them in a way that seems more intuitive rather than just the listed numbered items. So starting with consciousness, he's alert, correct. For age, month, you can obey commands. Language, no speech deficit, mild dysarthria because of his facial droop. Vision is normal, but if we wanted to, we could say that he has a left homonymous hemianopia, but for this, we're just going to say normal, and no visual inattention, no gaze paresis. So for motor, we're going to say that there is weakness there on the right side. The arm, some effort against gravity. The leg is not as bad. Left side is normal. No ataxia on the left side, and the right side, given the degree of weakness, there's no ataxia there. So as we can see, the the NIH is 6 as calculated just up here. So then move on to investigations. He's had a non-contrast brain, no acute findings. CT perfusion scan, we're going to say acute perfusion lesion in the left anterior circulation. There's also had a CTA, no carotid lesion. There is an intracranial occlusion, and we're going to say it's a left M1. Okay, ECG, normal sinus rhythm, no atrial fibrillation, and bloods have been done. Okay, and notice as we've ticked those things, those findings show up here, and those will end up on the final admission. Okay, moving on to management. In this situation, we've got a fairly low stroke scale in combination with a left M1 occlusion, and given the age, we've decided that the patient is within the time window and is eligible for both lysis and endovascular clot retrieval. So let's say young patient within the time window for lysis and also eligible for clot retrieval. And the working diagnosis, when it is selected here, the relevant aspects of the management are listed on this page below. So we've elected for lysis, and obviously a check sheet for contraindications does need to be performed, but provided that in this situation he doesn't, we're going to just work through it. So say 75 kilos, we've got a bolus calculation of 6.8 milligrams and an infusion dose of 60.8 milligrams. We're going to say that it was started about, it's going to be started now, so we're going to go 5:05 p.m. Okay. Basically, these are management initiatives that have been pre-prescribed for each patient depending on the working diagnosis. They're not all compulsory, but it is recommended that you go through each and determine which of these are appropriate and applicable to this patient. So obviously we're going to refer to an ECR center. We're going to notify the ED doctor, update the patient and the family. We're going to give the patient information sheet for thrombolysis and ECR to both the patient and the family. We've got to consent the patient. We've got to document that they're nil by mouth. Notes are completed and printed for transfer. And we've advised the nursing staff, usually by ticking this box, that the indwelling catheter and right groin shave need to be done such that it speeds up the procedure at the ECR center. And then just make a note that if tongue swelling does occur in transit, that either before or in transit needs to be, the patient will need to have their airway assessed. In terms of ongoing care, these are fairly standard and more or less compulsory aspect to the perilystis stroke care. So maintain blood pressure. We'll need pressor support if blood pressure drops below 120 millimeters of mercury systolic. Oxygen only if SATs are below 94. Maintain BSL less than 10 as per the FES protocol. Maintain temperature, 2 liters of IV fluids over 24 hours. And ECR center, must notify them. Obviously, as an interventionist, that's a very critical part of the assessment. And anything else which is specific to this consultation that is not here can be typed here. So I can't think of anything at the moment, but those issues will pop up presumably as consultations are done. And if they have other issues, for example, perhaps there's some concern about aspiration pneumonia, needs chest x-ray as soon as practical, and or antibiotic cover, needs to be entered there. Now, in terms of data capture, we've got to obviously have some of this information put into the system. Okay, so it's fairly straightforward. So it's so we're going to say that it was done by Timothy, and we were contacted at about 5 p.m. First contact emergency department. Did they use the ASAP tool, which is a way that they triage patients? So that's important. Whether or not, these are all relatively straightforward. So treatment decision we did at about 5:05. Okay. Reasons not thrombolized, really important. Reasons not sent for ECR. And so this page is typically standard for any diagnosis. And then in terms of day 1 to 3 follow-up, which will take place in conjunction with the remote site, and also where the patient may end up. So this part of the assessment doesn't have to be done straight away. It can be done later on, and your patient can be accessed from this list or from the main dashboard. The comprehensive center data for ECR can be also accessed here, and then 3-month follow-up. Now, this is obviously useful if it's documented straight away, but it's not necessary in order to produce an EMR note. So once all that information has been put in, you can see how easily it compiles the note based on what information has been entered in all the previous fields, and you can see that it's a fairly comprehensive consultation note. Okay, and at that point, click Copy All and mark the admission complete. This tells the system that you're finished, and this text will be in the clipboard, and at that point it will be copied and pasted into the local EMR. And that's basically it. And when you're finished, you just log out.